All right, students, I'm going to continue with the lecture for week 3. What am I doing? Oh, okay. So I threw a couple of slides in, and I've uploaded the new PowerPoint to include just these couple of slides. But so when we talk about preeclampsia, we talk about worsening preeclampsia, HELLP syndrome, a massive postpartum hemorrhage, sepsis, and any type of clotting cascade thing that's going on. This is what's happening. So we have endothelial, that's spelled wrong, disruption or damage to the blood vessels, resulting in injury. So then we have the platelet aggregation that plugs the hole. And then the holes that were created during the injury. And then intrinsic factors all come, clotting factors all arrive to help. And they further put a meshwork over top of the injury, layer by layer by layer. Okay? And then plasmin, which is converted from plasminogen, plasmin comes in and trims up that fibrin meshwork to perfectly fit the injury, okay? But then that stuff that has been trimmed off, that's called fragments, fibrin split products, actually, FSP, fragments of that meshwork. Those are cut off, and those are filtered out in the bloodstream. But what happens with DIC is those little fragments, they end up being go to the microcirculation, those micro vessels at the organ, at the end of, or at the organs. So that blood supply that's supposed to be supplying oxygen and nutrients to those organs is now also supplying them with all these little fragments. And that causes microclotting or microemboli at the organ level, which then damages each of the organs. So we're having this massive hemorrhage going on, this massive injury. We're lysing red blood cells. We're clotting at the microvascular level, and we're bleeding. So we're bleeding and we're clotting at the same time. And the body is trying to produce as much of the clotting factors as possible, but they have to produce them so fast that it can't keep up. So that's where we start seeing problems with our ability to clot. Okay? All right, so that's DIC and just a very simplified explanation. So what do? Well, we correct the cause. So the bleeding or whatever's going on. I'm sorry, I'm paying attention to my dogs. I hate recording at home. It's very distracting. Anyways, we determine the cause, we correct the cause, but then we need to provide support to this woman for the DIC that's going on. So we need to provide clotting factors, okay? But clotting is causing the problem. Yes, but clotting, we're making immature clotting factors. We're clotting all over the place because of the vascular damage. So we need to send clotting factors to fix the vascular damage. And then we also now need to provide blood replacement products because of her massive hemorrhage. Okay, so, we could be giving her some platelets, some cryo, and that would help with the clotting, and then we could start replacing the blood supply as well. So we're going to be doing an indwelling Foley catheter because we need to be watching her urine output, very big, huge indicator of volume status. Of course, we're going to give her oxygen because she's losing blood and not having enough to circulate oxygen to the tissues. And then, of course, emotional support. Of course, she's emotional support for the family, she's probably a little bit out of it at this point. And if she still has a baby in there, of course, we're going to be doing fetal assessments as well. But our interventions are focused at mom. Yes, baby is going to look bad on the monitor, okay? But we can't fix baby unless we fix mom. So I'm not saying ignore the monitor. I'm saying that as a result of mom status, that's what's wrong with baby. So we've got to focus on fixing mom, and then we can fix baby, okay? Or that will also fix baby. So don't get hung up on your monitor. Fix mom, and then that, oops, I didn't mean to do that. That will fix baby. Okay. All right. Multiple gestation, I do want to touch on this really quick. We have a lot of multiple gestation at the hospitals. There's two different types of, there's three different types of multiple gestation. There's two different types of twins. And then, of course, there's your triplets and quadruplets and quintuplets and sextuplets and whatever. But we're going to focus on twin gestation. There's two different types of twin gestations. The first type is fraternal or dizygotic twins. So break that word down. Di means two. Zygotic means fertilized egg. So we have two separate fertilized eggs. They are as different as a 8-year-old sibling is to his 5-year-old sibling, except they're being birthed not 3 years apart, but together. Okay? And then we have identical twins, which is your monozygotic twins. Hold on, I'm moving out of this room. I'm sorry. Monozygotic twins. Hold on, I'm sorry. Please be patient. Okay, moving to a new room. Oh crap, now my phone's ringing. All right, I'm going to ignore it. Okay, sorry. Monozygotic twins. Mono meaning one, zygotic meaning fertilized egg. We have one fertilized egg. How do you get twins from one fertilized egg? Well, they split. And they split in that first week, somewhere in that first week of fertilization. So if we have a dichorionic, diamniotic, that means we have 2 and 2 of something. So we have 2 chorions, which is basically the membrane that the placenta is developed from. So basically we have 2 placentas, and then diamniotic means 2 amnions, which is the inner bag of waters where so it's the inner layer of the bag of waters. So we have 2 of those. So we have 2 placentas and 2 bags of water. So basically, it's like they're in their own little separate cavity, kind of similar to the fraternal or dizygotic twins, okay? The dizygotic twins above, the fraternal, the non-identical ones, they each have their own placenta, they each have their own chorion, they each have their own amnion. They're just totally separate beings, just being born at the same time. But the dichorionic, diamniotic comes from one single fertilized cell, egg, that has split in the first few days after conception when the chorion and the amnion aren't fully developed. So once they split, then they're able to develop 2 separate chorions and amnions, almost like the dizygotic twins. And these are identical twins because they come from the same fertilized egg. The next kind of identical twins is the monochorionic diamniotic. So mono meaning one. So they have one chorion or one placenta and one or two amnions, which is two separate sacs of babies. Okay. So they share a placenta. Okay. This division happens later after that fertilization, somewhere after 4 days, somewhere within that week, but after 4 days. Now, the monochorionic monoamniotic is one chorion, one placenta, one amnion, one sac. So they're both in the same bedroom, basically. Okay. This division happens after that first week of fertilization, and you will often hear the slang when we talk about twins, when we say, what kind of twins do you have? Someone might say, I have a di set of twins. So that means dichorionic, diamniotic. Or they might say, I have a mono-di set of twins. That means monochorionic, diamniotic. Or they might say, I have a mono-mono set of twins. But when you look at these definitions, which ones do you think are the most risky? Which ones have the most risk factors? Okay. It's the mono-mono is the highest risk twin setup, and then the mono-di is the next level of risk. But mono-mono is the highest risk because the babies are sharing everything. There may be some competition for nutrients, and maybe one baby gets everything and the other baby gets nothing. And then another complication with babies that are monochorionic, so the mono-mono or the mono-di, where they're sharing the placenta, we have something called twin-to-twin transfusion. And there's a donor twin and a recipient twin. So just think of it like one twin is donating blood to the other. So that one twin that's donating is not getting enough blood supply and enough oxygen and nutrients, and the other twin is getting a lot. And this is where we'll have that discordant growth pattern where one baby will be very small and the other baby will be larger because the other baby is getting all the nutrients. So there's a lot of complications, cord entanglement, all kinds of complications with each type of multiple gestation. So how do we diagnose it? Well, of course, ultrasound, and we see multiple gestation sacs and yolk sacs. We haven't learned about that yet, but so we basically just see multiple baby things going on in there, okay? We can also, if we didn't do the ultrasound, we could maybe suspect it because the woman's uterus is growing a lot faster than we anticipate for her gestational age. She has more weight gain than we're anticipating. And if we're doing Leopold's maneuver and palpating, we feel more fetal parts than we would think we would be feeling if there was just one baby in there. If we do a urine test or a blood test, we would see higher than normal labs results than we would see with just a singleton pregnancy. Now, we can see when we diagnose this with ultrasound, it has to be somewhere after 10 to 13 weeks that we're able to detect this well enough. And then when we take care of these women, they're going to start getting more frequent, they'll probably have more frequent prenatal visits, but these women a lot of times end up threatening preterm labor or maybe even a PPROM because the weight of that pregnancy puts stress on the uterus and the amniotic membranes, and we could see a rupture of membranes prematurely or pretermly, and so she may be an antepartum patient for a period of time till we decide that she's far enough along to have her babies. And so Oop, I'm sorry, I keep touching. And so she will deliver at a level 3 facility, which community medical center is, and I do believe that St. Pat's is doing twin deliveries as well. Okay. Now, I'm not going to go through the infections except for a couple. So UTIs, I'm going to go through. GBS, I'm going to go through. But the rest of them, I want you to review on your own. But these we will see most often. So we have a lot of women coming in thinking that they're in a preterm labor. They're having premature contractions. And indeed, we put them on the monitor and we see contractions. Two common reasons for preterm labor are a urinary tract infection and dehydration. So we get these gals in, we get a urine sample, we send it to lab, and typically it comes back showing a UTI, even though the woman says, I don't have any symptoms of a UTI. I don't have a urinary tract infection. I know what those feel like, and I don't have one. Well, a lot of times urinary tract infections can be asymptomatic in the pregnant person, so they don't feel those symptoms. But except the symptom of having contractions. So we hydrate her, and then we give her antibiotics to treat her UTI, send her home, and then she is, most of the time, she finishes her antibiotic course and goes to term. So anyways, some of the medications that we would use is ampicillin, Ancef, Keflex, and then if the woman is having, is definitely having symptoms of a UTI where she's having painful urination, we can also give her, I can't remember the class that it's called, but it's that pyridium that is kind of like an analgesic for the bladder to help with the pain of urination when she has a UTI. But again, a lot of times they don't, that's pretty rare that we even give that because most of the time women are very asymptomatic with their UTIs. She can also have, there's a lot of women that end up with a kidney infection. So she has this asymptomatic UTI and she doesn't maybe feel contractions or they don't feel any different, or, she doesn't come to the hospital with her contractions. And so she stays at home and lives life. And then that UTI ascends and now she has a pyelonephritis or a kidney infection. So on exam, she will have flank tenderness. So when we do our CVA exam, percuss her flank area, she's going to have tenderness there, nausea and vomiting, fever, chills. And when someone has a kidney infection, they do need hospitalization because they need IV antibiotics. So we'll put her in the hospital. She'll be on fluids and IV antibiotics. She will not be NPO. She will not be on bed rest. We will treat her, and of course we will do frequent monitoring of the baby and if she's having contractions. But then when she is done with her IV course, then we may discharge her on some PO antibiotics, and then life will be well. Okay. The next infection I want to talk about is group beta strep infection. It is actually, a group beta strep flora. That's a better word for me to use, because sometimes this bacteria is a common flora or a normal flora of some people's anal and vaginal regions, okay? Some of us have it, some of us don't. And some of us that do have it may have it and then later may not have it. So it's not an issue for the person. However, it is an issue for the baby. So if a woman has a positive GBS culture, then we know, and we're going to do that culture around 36 weeks is typically when we do that. We send that culture, it's a swab, it's a vaginal anal swab, and then we send it to lab and they culture it. If she comes back positive, then of course we indicate that in her records, and then when she goes into labor, we will treat her with antibiotics during labor. And typically penicillin is the drug of choice. If she has an allergy to penicillin, then we will use clindamycin. And we like to have we like to have 2 doses given to mom before the birth of the baby, and we like the last dose to be given within 4 hours of the birth of the baby to be comfortable that baby is adequately prophylactic. So it's prophylaxis for the baby to prevent the baby from getting a septic group beta strep infection, which can be really, really fatal for the baby and really bad. It's just because the baby gets a group B strep infection does not mean they're going to die from it, but it's a quick, a rapidly proliferating infection for baby and can be very overwhelming to baby systems. And every bodily system would be involved, and the baby will need to be on like a 10-day, it's a 7 to 10 day course of gentamicin and ampicillin. And they'll be in the NICU and all that kind of stuff. So we want to try to prevent that. Now, do we not do this test on women who are planning a vaginal birth? Well, you would think no, because the baby's not coming through the vagina. But that's our plan. That doesn't necessarily mean that will happen. So even if this person has had a previous C-section or whatever reason, if she goes into labor and vaginally births that baby and we don't know about her strep status, then we need to assume, and this is what we do, we assume that she had group B strep, and we put the baby on, baby's still newborn until proven otherwise, but our assessments of the babies will be more frequent so that we can watch to see if baby's starting to show signs of infection. And then we typically like to keep these babies for more than 48 hours because it may take more than 48 hours for that infection to build and present itself. So if a woman has not been tested for group B strep and she comes into labor, we will assume she is GBS positive and we will do antibiotics on her anyway. It does not hurt to do it. It does not hurt mom or baby for us to do antibiotics, even if there is not a GBS flora present, but it will hurt if there is one present and we didn't treat for it. So that's the explanation for group B strep. So let me know if you have any questions about that explanation. I think I went through it pretty quick. So the torch infection is something we test for. We test for STIs, sometimes chlamydia and gonorrhea. Sometimes the patient will refuse. So if this is a woman that's been in a monogamous relationship, she's never had chlamydia and gonorrhea, and as far as she believes, her husband is he still monogamous as well, or her partner is still monogamous, so she doesn't feel any reason to be tested for chlamydia and gonorrhea, then sometimes you will not find this in the prenatal records. So look for it. It may be there, it may not. If it's not, then we're not going to get all hoopty-doopty about it. We do test for syphilis. It's the VRP, RPR, VRPL, something like that in the prenatal records. That is the syphilis test. We do not typically test for HPV during pregnancy. HIV we test for in pregnancy. You can read through this. The one thing I will say about HPV is we don't have a large population and of HIV positive women in this community. And there's a couple of different views as far as vaginal deliveries and breastfeeding. And most people err on the side of caution. So if you have HIV, you don't do a vaginal birth, you don't do breastfeeding. But some people, especially if they work with a large population, there is a philosophy out there that if we test mom's viral load and it's less than 1,000 copies, then the chance of transmission to baby is less than 2%. So they will give the woman the option of a vaginal birth and breastfeeding. So there it is. But I think here, I think since we have such a low population, we don't, no one wants to take on that risk. So I think everybody is on the boat of no breastfeeding, no vaginal birth with HIV infection. Okay, hemolytic disease I am going to go over because it's a big issue in pregnancy when it comes to ABO and RH. And actually, ABO is less of an issue than RH. We can have some ABO incompatibilities, but they don't present the problems for babies that the RH incompatibility does. And so if we do have a mom and babe that have an ABO incompatibility, we just end up watching the baby a little closer to make sure baby doesn't show any signs of hemolytic disease. And what that would be is a jaundice. So if there was an ISO immunization of ABO, meaning that mom produced antibodies against baby's blood cells, and those antibodies crossed the placenta, and they started attacking baby's red blood cells. That attack is very minimal, and so if that attack did occur, we might see some jaundice, right? Because jaundice is the name of the disorder of hyperbilirubinemia, where the skin turns yellow, and hyperbilirubinemia is a result of red blood cell breakdown, right? So if we have an ABO compatibility or mom's antibodies to baby's blood type, then those antibodies would break down some of baby's red blood cells. Anyways, but what I'm really going to focus on is RH, okay? And so that's the one that presents the most problem to us. Now, RH is when we say that someone's blood type is A positive or O negative, that positive or negative number is referring to the RH, the rhesus antigen, okay? And so if she's, let me make sure, rhesus, anyways, so if she's Rh negative, then that means she does not have that antigen on her red blood cells, okay? If she's Rh positive, then that means she does have that antigen on her red blood cells, okay? Now, I'm going to make sure I don't get ahead of myself in these slides because I don't want to confuse anybody. All right, so if mother is Rh negative, meaning she does not have that Rh antibody, and for some reason mother gets exposed to Rh positive blood, then mom's body will look at that positive antigen, will look at that antigen and produce antibodies to attack that antigen and kill it, okay? So if she produces antibodies, those antibodies do cross the placenta. And so those antibodies against Rh positive blood will cross the placenta, and if baby is Rh positive, then those antibodies will completely obliterate baby's red blood cells that have that antigen on it, okay? And so the question is, what is baby? Well, we don't know until baby's born, okay? So what would cause mom to be exposed to baby's blood? Well, if mom had a previous blood transfusion where someone messed up and gave her Rh positive blood, if she had anything that was a traumatic anything in her pregnancy, so maybe she had a previous abortion or miscarriage, and during that process, mom was exposed to some of that pregnancy's or that baby's blood cells. Well, was that baby that she miscarried, was that baby Rh positive or Rh negative? Well, we don't know. So she could have been exposed, and she could have been and start producing antibodies. And she will have those antibodies usually for a lifetime. And if she gets pregnant again and has an Rh positive baby during her pregnancy, then her antibodies will cross the placenta and attack that future pregnancy. Well, any other procedures or traumas or invasive things that happen to mom during a pregnancy can expose mom to fetal blood cells. So if we do any invasive uterine procedures, like if we do an amniocentesis where we stick a needle into her uterus, into the amniotic fluid, okay? If we do chorionic villus sampling. Well, we haven't talked about that. We'll learn about that in a few weeks, but that is another invasive uterine procedure that we do during pregnancy. If she has a placental previa or a placental abruption, we did just cover those Wednesday. Those could expose mom to blood, baby's blood. If she had a previous C-section, during the labor, or not a previous C-section, during the C-section, she could be exposed at that moment. During labor and delivery, she could be exposed during that process. And so we need to do things to check up on that. Okay. So let me not get ahead of myself. So when the woman comes in for pregnancy, we're going to do prenatal labs, and that includes checking mom's ABO and RH. Okay. If mom is RH negative, then we will also test her blood and do an indirect Coombs test. An indirect Coombs test tells us whether or not she has produced antibodies. And when she produced these, it doesn't tell us. It's not when she got pregnant. The fact of getting pregnant doesn't cause her to produce antibodies. But a previous experience or previous exposure is when she produce those antibodies. Okay. So we're going to do this indirect Coombs test. If that test comes back negative, then she hasn't produced antibodies. Okay. So great. Life is great. And we're going to go forward with her pregnancy. And then at 28 weeks, we're going to rescreen her to see if she has produced any antibodies. When we rescreen her, if it's negative, we are going to go ahead and give her RhoGAM, 300 milligrams, IM, and Rovac, I think, I can't remember. Is an IV version, so we can give the IV version in the hospital when she's after she's delivered. But usually on a 28-week mom who doesn't have an IV site, we will give the IM, RhoGAM IM. This prevents her from forming antibodies. And more specifically, the RhoGAM coats any red blood cells from the baby that she may have been exposed to or will be exposed to. And that is what prevents mom from making antibodies, because her blood can't see the Rh negative. Okay, so it coats and destroys the fetal red blood cells, and mom doesn't know they're there, so she doesn't create antibodies. Okay, now let me just skip ahead. Okay, I'll go back to that previous slide. What I want to say here is, if mom is positive, when she first came in for her prenatal visits, and we did her prenatal panel, and we did that indirect Coombs test, and we found out she has antibodies, then that means she is indirect Coombs positive. The test will be positive, and then we will say that mom is sensitized, isoimmunized, or alloimmunized. Okay, I'm sorry, I'm not saying those words correct. So she has been exposed to Rh negative blood, and she has created antibodies. So what do? How do we protect that baby from antibodies crossing the placenta? Well, we monitor that pregnancy more frequently. We will do ultrasounds to look at the amniotic fluid. The test that we will do is called the optical density test. And it just looks at the density of the amniotic fluid. And if the optical density test is low, then we feel like there has been no attack on baby's red blood cells. We are not seeing an amniotic fluid with a bunch of bilirubin floating around in it. That's why the density is low. So we feel that if there is a reaction, it's very low, and we feel baby's not at risk. But if the optical density is very high, then we feel like there's a lot of bilirubin circulating in the amniotic fluid, and we feel that this baby is having a severe hemolysis reaction, and it is now in jeopardy. Okay, so all right, let me stop there and come back. So that was the mom that was Rh positive. Now we're coming back to this mom that's Rh negative. At 28 weeks, we have repeated that ABO-Rh antibody screen, and it's negative again. We've given the RhoGAM, and that RhoGAM will take care of mom for about 3 months, which is about how long it's going to be until she goes into labor. And then when she goes into labor, we will collect cord blood. The cord blood is going to tell us what the baby's ABO and Rh is. So we're going to test that cord blood, and if baby is Rh negative, then we can just forget about the Rh negative problem. There's no problem, okay? Mom's Rh negative, baby's Rh negative. But if baby comes back as Rh positive, then we need to prepare to give mom RhoGAM. Now, if baby's Rh positive, we can do a Kleihauer-Becky test, one to determine to determine how much fetal blood cells mom has been exposed to, which will determine how much RhoGAM we need to give her. Okay, and then once we've done that, then the lab will say, the lab will do the test, and then they will say, you just need to do the 300 again, 300 milligrams of RhoGAM, and we need to give that within 72 hours. Okay. All right. And then we could possibly do a direct Coombs on the cord blood and determine how many antibodies have crossed into fetal circulation. So we usually do that. We don't typically do that all the time unless actually I'm trying to think. I don't see that done very often anymore. Anyways, but that is a test we could do on baby, is a direct Coombs. Remember, we did an indirect Coombs on mom. We're doing a direct Coombs on baby. All right, so we've talked about the positive mom. We've talked about doing the amniocentesis and looking at optical density. The density is how much bilirubin is floating around in the amniotic fluid. A very high density means there's a lot of bilirubin, so baby is experiencing hemolysis. And if it's a low density, then we feel like either baby is Rh negative, so there's no reaction going on, or if baby is Rh positive, there's very little reaction going on where we don't feel baby's in jeopardy. All right, moving on. Okay, so if we do have an Rh isoimmunization and antibodies do cross the placenta, then they do attack baby's red blood cells. So we have a baby in utero that has a red blood cell deficiency. Our fetal bilirubin levels rise. So we have a hyperbilirubinemia. Our fetal bilirubins rise, and that's called icterus gravis. Okay, and then when we start seeing severe neurological disease, that's called bilirubin encephalopathy. Okay. Now, when babies are struggling with this red blood cell hemolysis, then their body is trying to reproduce red blood cells very quickly, and they end up producing what's called erythroblasts, which are not mature red blood cells. And if they're not mature red blood cells, then they are unable to carry oxygen. So baby is in a state of hypoxemia and hypoxia, which we call erythroblastosis fetalis. Okay, and then that can progress to severe fetal edema, generalized or whole body edema, and we define that or term that as hydrops fetalis. And then that baby in utero goes into congestive heart failure. So this is really bad. Okay. Now we can see fetal hemolysis on ultrasound. Again, remember looking at the optical density, but we can look at baby and we can see an overwhelming edema. We can see ascites. We can see an enlarged heart. We can see hydramnios or too much amniotic fluid. We can do another invasive test called a percutaneous umbilical blood sampling, and we can actually quantify baby's CBC, basically, or red blood cell count. And that will determine the amount of hemolysis, quantitatively determine the amount of hemolysis. So it's basically just doing venipuncture on mom, getting a blood sample from mom, but it's doing it through the uterus on the umbilical cord to get baby's blood. All right. And then if we feel like baby is having severe anemia where these other things are resulting, to protect the baby from this, we can do intrauterine blood transfusions. So where we go in through the uterus and we cannulate that umbilical cord and we do a blood transfusion through the umbilical cord. Of course, we're going to give O negative blood. And we did have a patient once who she wasn't an antepartum patient, so she didn't live at the hospital, but she came every week, and she had this severe isoimmunization going on, and her baby got a blood transfusion every week. And I think she went to term or close to term, or maybe they decided at 36 weeks they were just going to induce her because of this, but baby did fine, mom did fine. Okay. So back in the day, years ago, we didn't have these options to check on baby and on mom. So children were born with this, and sometimes they died shortly after birth. And then sometimes they had, lasting neurological disease after birth. Did I skip something? No. Okay. So, ABO incompatibilities, I kind of talked about this a little bit. So this occurs when mom is blood group O. So just like RH, when mom is blood group O, she doesn't carry any antigens, any red blood cell antigens, right? So if baby is type A or type B or type AB, then those antigens on baby's red blood cells, mom sees, she creates antibodies. So the same thing goes on. And we can do the direct Coombs on mom. On babe. We can do the indirect Coombs on mom. But typically we just monitor these patients, and there's really no major sequela that happens, and we don't usually treat, even if there is an incompatibility. Maybe if we do anything at all, it may be just a simple, baby needs Billy lights because baby's a little bit jaundice. And so there's that. Okay. Oh my gosh. I thought I didn't have this much. Okay, diabetes and pregnancy. So I'm not going to explain diabetes mellitus, type 1, type 2. You guys already know about that, but women that are diabetic can get pregnant, and so their diabetes and pregnancy can be an issue, or women can develop diabetes during pregnancy, and that's called gestational diabetes, because after pregnancy, then she no longer has diabetes. However, she is at risk, one, for developing diabetes, overt diabetes, sometime in life, and then she also has a risk of gestational diabetes and future pregnancies. Okay, diabetes, gestational diabetes, or GDM, develops later in pregnancy, and I will explain why. And usually, most of the time, these women can be managed by diet and exercise, but occasionally we will put them on some oral medications, and very rarely will they need insulin. But a patient who is type 1 or type 2, of course, probably insulin is going to occur, well, especially with type 1 insulin, but even type 2 where they may be on oral diabetes medications, they may end up needing insulin as well. Okay, so during pregnancy, so in the first part of pregnancy, mom mom is storing large amounts of fat and protein, and storing her glucose. Okay, so and storing this glucose for the later part of pregnancy. Now, during the later part of pregnancy, she's breaking down all that storage, and to supply baby with the glucose baby needs, because glucose does cross the placenta. But then also in pregnancy, a normal part of pregnancy is mom has an increased resistance to insulin, and she gets that resistance from hormones produced by the placenta. And the purpose of that is so that mom won't store the glucose. It's so that that glucose will still circulate in mom's bloodstream, therefore eventually getting to the placenta and crossing over for baby. So that's why diabetes, GDM, gestational diabetes, we see it causing a problem in the second half of pregnancy. Okay. Now, what happens for baby is when, so when gestational diabetes occurs, then this person, she doesn't, so normally in pregnancy, there's an insulin resistance. Okay. So baby gets some glucose, but when gestational diabetes occurs, it's because, that insulin resistance is more than what it should be. And, mom is not storing, the glucose that she needs to store for herself. And so that's why her blood sugars are higher, is because, she's just having an abnormal reaction. So it's not a normal resistance to the insulin as in most pregnancies. Okay. It's an exaggerated resistance to the insulin. So mom becomes hyperglycemic, which means there's a whole flood of glucose that's able to cross the placenta and go to baby. But mom's insulin that she produces, because of all this glucose, does not cross the placenta. So now baby does produce insulin to handle the glucose load. All right. So now, because of all that storage, now we have these very beefy, large babies. And then another result is it decreases their surfactant production. So a lot of these babies of gestational diabetic women or diabetic women, that's where we see these super large babies. And then those babies also have respiratory difficulties after birth. Okay. So what we do is we screen all women between 24 and 28 weeks. And if they have a particular history when we first have them come into our prenatal clinic, with risk factors and things like that, we will do early screening, but otherwise, it's around 24 to 28 weeks. And we can just do this simple, 1 hour glucose check, where they have this 50-gram oral glucose solution, and then an hour later we check their blood sugar. And if their blood sugar is less than 130, then we're good. We feel that this woman is not gestational diabetic and everything is good. However, if her blood glucose is greater than 130, then we have to move to the 3-hour glucagon tolerance test. Okay. So the 1 hour one is, she's not required to fast, but this 3-hour one, she's required to fast. Then she drinks this, she's required to fast, and then we check her blood sugar. Okay. And then, she drinks this 100-gram glucose solution, and then we check her blood glucose at hourly intervals at 1 hour, 2 hour, and 3 hours. Okay. And she can't eat or anything during that 3-hour time period. So we've checked her fasting. She drank the fluid. Then we check her 1 hour. Then we check her 2 hour and check her 3 hour. If she is above any of these parameters on any two of these testing periods, then she will be diagnosed with gestational diabetes. So hopefully her fasting is less than 95, but if it's not, then that's one strike. And then her 1 hour, if it's less than 180, that's great. If it's not, if it's greater than 180, then that's strike two, and she's gestational diabetic. And maybe her fasting was normal, maybe her 1 hour was abnormal, maybe her 2 hour was abnormal, and maybe her 3 hour was normal. But anyways, it only takes two abnormal values, and she's going to be diagnosed with gestational diabetes. All right, so then what do we do for her? Well, she might go see the perinatologist, which is Dr. Holbrook and Dr. Fawcett. She might have an endocrinologist. However, most gestational diabetics are managed by their obstetrician. However, if she's overt diabetes, she probably already has an endocrinologist on board. And of course, she's going to see a nutritionist or dietitian, and maybe a neonatologist, but that's not unless baby is born premature or has problems that we feel baby's going to be admitted to the NICU. Most patients, well, we can have patients do home blood glucose monitoring. And typically what they do is they do a fasting in the morning, and then they do 2 hour postprandials. Some people do pre-prandials, but mostly, so that's doing their blood sugar before they eat. But most people do 2 hour postprandials, so 2 hours after they eat. And if it's less than 120, then they're good with life and they can go on. But if it's more than 120, then they probably have an insulin coverage, a sub-Q insulin coverage that they need to take. So we do have them, try to follow a healthy diabetic diet. They may be on some oral glucose medications. Of course, we're going to encourage them to have some sort of physical activity every day. And then we're going to be doing fetal and maternal surveillance or well checks more frequently. So we're going to be doing ultrasounds throughout the pregnancy so that we can keep watch on baby's growth and the amount of amniotic fluid. And then, of course, we can look at baby and see if baby is having any developing, or we're noticing any anomalies or defects, okay? Especially with women who are overt diabetic, and especially if they're what we call brittle diabetics or uncontrolled diabetics, we can see a lot of fetal anomalies. So high glucoses in mom during that first trimester is like a teratogen. It can cause severe congenital anomalies, and anomalies that are incompatible with life. So anyways, with gestational diabetics, we don't typically see all those problems, those kind of problems, but we still watch for them because it doesn't mean it won't happen. So what kind of medications can the woman take? Well, if she's on insulin, of course, insulin is subcutaneous, so she may have insulin pens, or she may need to draw up her insulin, so we might need to educate her. Well, of course, we're going to educate her even if she has insulin pens. But some patients, especially those overt diabetics, they may have subcutaneous insulin pumps, okay? So they could have short-acting and long-acting regimen. And then we don't usually give any hypoglycemics because they cross the placenta. But metformin is one of those hypoglycemics, especially if they've taken it because that's what they were on as a type 2 diabetic. It does cross the placenta, but for some reason we don't see a lot of harm to baby with the metformin. But the other hypoglycemics we do. Okay, or some patients we can start on glyburide. So it's a oral sulfonylurea, and it does not cross the placenta. Okay, so they might be on those. All right, venous thrombosis. I want to talk a little bit about that because pregnancy is a hypocoagulable state because of increased blood volume, because of venous stasis. Then women are at increased risk for developing blood clots. So we just assess for that. We don't do any fancy assessments like diagnostic tests for that. But some women do have histories of blood clots or pulmonary embolisms. We even did have a patient last week or this week at the hospital who had a jugular blood clot. So some people come into pregnancy with some sort of clotting disorder or a previous history of a clot. And so we need to watch these people more closely. Okay. So if they have a history, even if they don't have a current blood clot, they will be on heparin or Lovenox. And then when they get to labor, they will probably be on a heparin drip, because we can titrate that heparin drip based on their PT and PTTs. They will be on bed rest with elevation. If they have a blood clot, we will apply warmth and warm, moist heat to the area of the blood clot. If they do have a blood clot, we diagnose it by ultrasound, and then manage the woman for that blood clot. But even women who do not have a current blood clot, but if they have a history, they will be on Lovenox and then heparin at delivery. Please look through the psychiatric disorders section. I'm not going to go over that, and be familiar with some of the problems there. Oh, shoot. Okay. Sorry. I do want to go over these things. So these are antepartum fetal assessment tests. So I talked about chorionic villus sampling a few minutes ago. So that's where we go in and take a sample. We go in not vaginally, I'm sorry, through the uterus, I'm sorry, and we scrape a little bit of the chorionic villi. So that's off the placenta area, and we sample that for genetic problems or things like that with the baby. We do that at 10 to 12 weeks when we can get to that area. We do it under ultrasound guidance. A catheter is inserted. We scrape or aspirate a little bit of that chorionic villi, and we send that for testing. A lot of risks with this test. So, of course, infection, fetal loss. So this is 10 to 12 weeks. So imagine how small that fetus is. We could actually rupture the woman's bag of waters. We can cause an Rh isoimmunization if mom is Rh negative. We could cause fetal limb reduction. So we have such a small fetus, you know, and this procedure, like it only takes a tiny touch of that fetus and we might amputate a limb. Okay, so this is really a risky thing. So this is not something that we offer willy-nilly. Okay. Anyways, percutaneous umbilical blood sampling. I did talk about that with testing baby for hemolysis. So we can test baby's ABO. We can test for anemia. We can test for isoimmunization. We can also test for metabolic disorders and infection. We really can't do this until after 18 weeks. It's also ultrasound guidance through the uterus. The needle's inserted through the maternal abdomen into the fetal circulation, umbilical cord circulation. Risk is cord laceration, of course, thromboembolus in the cord, preterm labor, preterm birth, preterm rupture of membranes, and infection. All right. So we do these when we have to. These aren't just willy-nilly like drawing blood from mom. Amniocentesis you might see done more often. We can do these after 12 weeks. This is where we just remove some of the amniotic fluid for testing. Okay. Ultrasound guidance, needle inserted through mom's abdomen into the amniotic sac. We withdraw some amniotic fluid. We can test for chromosome abnormalities. We can test for fetal lung maturity. Because we're looking for different proteins in the amniotic fluid that show us fetal lung maturity. We can look for infection. We can test for the presence of bilirubin. And we can do amniotic fluid reductions. We have done this at Community Medical Center. So someone who's severely hydramniotic, meaning they're producing large amounts of amniotic fluid, that's not good for mother or baby, so we have to withdraw. And on this particular patient, I can't remember how much we withdrew every week. It was a very large amount, like a liter total. And we did this every week until she delivered. Risks for doing this procedure, of course, rupture of membrane, preterm labor, preterm birth, infection, fetal injury, so we can stab the baby with a needle, fetal death, isoimmunization if mom is Rh negative. Okay, I'm not going to talk about fetal lung maturity. You can look at these two tests that we can do on fetal lung maturity, but never, ever, ever have I seen this done in the past, I don't know, 6 to 8 years. Okay, because of the fact that we require the standard of care for doing induction is unless you have a medical or an obstetrical reason to do the induction, you don't do them before 39 weeks, and after 39 weeks, we're calling baby's lungs mature without even doing this test, okay, after 39 weeks. Before 39 weeks, if we're doing an induction or doing a delivery, it's because of a medical or obstetrical reason, and that reason overrides fetal lung maturity. In other words, mom and or baby are safer if baby is delivered, and then we manage baby. We manage baby's immature lungs after baby is delivered. So they don't even do these anymore. Okay, we are just assuming that baby's lungs are not ready, and so we had the NICU team on board and ready to manage baby if we're delivering before 36 weeks. Okay. We can do an amnioscope, so it's just a scope to visualize amniotic fluid. This is through the cervix, so this is not really like a needle through the abdomen like an amniocentesis. This is a scope. We go in through the cervix, we visualize, we can visualize amniotic fluid for the presence of meconium. A fetoscope is pretty much the same thing, but we insert this via like an amniocentesis route to visualize the baby. I have not ever done an amnioscope in my practice, 22 years. I have never done a fetoscope in my practice. So I doubt even if you work in OB, you'll ever see these, okay? Anyways, okay, so ultrasounds are done a lot. We can do them vaginally or abdominally, and we would do an ultrasound to confirm viability. In other words, to confirm if we have a live baby in there. We're looking for heartbeat. We can guesstimate gestational age. We can guesstimate the size of the baby, or how many babies are in there, of course. We can see how the baby is laying in there, what position they're in. We can look for any uterine or baby abnormalities. We can measure the amniotic fluid volume. We can do a biophysical profile and fetal Doppler studies. Fetal Doppler studies are things that we look at the blood flow through the baby's circulation to see whether or not we are having good flow, adequate flows. Ouch. Hold on. I gotta change position. I'm getting stiff. Ooh. All right. And I'm going to talk about biophysical profile a little more in a minute. Fetal kick counts. We have moms do this a lot, especially if we're monitoring baby for any doing extra surveillance on baby. We can have mom help us out by doing fetal kick counts at home, and we want mom to go somewhere quiet with her feet up on her left side, maybe have something to drink. No distractions like TV or music or something like that, or 20 kids running around. And we want her to concentrate on baby movements. And what we're looking for is 10 movements in 2 hours, or a minimum is 4 movements in an hour. And we have her do this several times a week. And each time it should be equal or better than the previous time. And if it's not, then we need her to come in so that we can do our surveillance. Okay, so those Doppler studies that we do on baby's blood flow, so it's studying the blood flow through the baby's umbilical vessels. It tells us about fetal circulation. We can determine fetal cardiac function, and it's non-invasive. It's done by Doppler, and so sometimes when they have babies that like twin-to-twin transfusion, or if they have babies that are severely IUGR, intrauterine growth restricted, or having problems with growth or something like that, then they will do these, or Dr. Fawcett will do these, or Dr. Holbrook. But otherwise, these aren't the typical standard testing that we do. Now, non-stress test is something we absolutely do very, very, very frequently. Okay, it's an evaluation of fetal well-being. It tells us about baby's oxygenation, which also tells us that baby has an intact central nervous system and a functioning myocardial reactivity, or a good reactive heart. Okay, we can start these tests. Baby is mature enough and developed enough to start these tests somewhere between 28 and 32 weeks. If the baby is 28 weeks and can't pass this test, then we don't say the baby is having a problem. We do other tests to look at fetal well-being. But if baby passed this test at 28 weeks, then baby should always pass this test. At 29, at 30, at 31, at 32, and until delivery, baby should always pass the test. So when baby is mature enough to pass this test, then baby should always pass this test. Okay? Now, we can say that the baby has a reactive NST or a non-reactive NST. Okay? A reactive NST is a positive fetal well-being assessment. A non-reactive NST is a negative fetal well-being assessment. Okay? Reactive, if you break these words down, reactive means positive. Non means no stress test. So positively, no stress. That's what we're saying. When we say non-reactive, non-stress test, non-reactive meaning negative, or no, and then non-stress. No non-stress basically is a double negative. They cancel each other out, and that means stress. Okay? Anyways, to qualify for a reactive non-stress test, on a baby that's greater than 32 weeks, we should have 2 fetal heart rate accelerations that meet the criteria of 15 beats above the baseline for 15 seconds. So that's 15 by 15 rule in a 20-minute period. So we need to see 2 of those accelerations in a 20-minute period. Now, remember when I was telling you about fetal heart rate assessment, we were talking about all those parameters, and I said, well, in this segment that I'm looking at, I don't have any accelerations. Is that a bad thing? And I said, no, not necessarily. Or no, that's not a bad thing. So I will look at the next segment, and in one of the segments I will see an acceleration. Well, so in this 20-minute segment that I put the woman on, if I don't see any accelerations in that 20 minutes, I don't say that the baby has failed the test. I give her another 20 minutes. So we give a total of 40 minutes for baby to show us 2 accelerations, basically. But those 2 accelerations do have to be in a 20-minute period. So if you have a patient on a monitor for 40 minutes, okay, and you see an acceleration, and then you see your second acceleration, and that second acceleration is 30 minutes later, then the baby did not pass the test. Those 2 accelerations, somewhere in that 40-minute period, those 2 accelerations have to be 20 minutes apart, less than 20 minutes apart. Okay, do you understand that? So anyways, if that occurs, then we can say baby has a reactive non-stress test. If the baby is less than 32, so somewhere in that 28 to 32 weeks, we drop the standard to a 10 by 10 rule. So 2 fetal heart rate accelerations that are 10 beats above the baseline for 10 seconds in that 20-minute period. Okay? If we don't have that, and we've done this test for 40 minutes, then we call the physician and we say, I have a non-reactive NST. It does not meet the criteria for passing the non-stress test. Okay. The other thing is I call the physician, I have an unsatisfactory test. Why? Because I have inadequate fetal activity or an inability to interpret. So maybe the baby is super active and I can't keep the baby on the monitor to get the tracing to see definitely that I have these 2 accelerations. Okay, or maybe baby in the 40-minute period, maybe baby has done nothing. Maybe that whole time baby has not done anything to generate an acceleration. So I would say either it's a non-reactive or an unsatisfactory test, and if either one of those occur, we will do another test. What is that other test, you say? It is a biophysical profile. That's the one I just said a few minutes ago. I'll tell you about that. A fetal biophysical profile. Basically what a fetal biophysical profile is, that NST that we did that baby did not pass, and an ultrasound. Okay? And the ultrasound looks at 4 different things. Fetal breathing movements. So baby in utero do have breathing movements. Like, they're not in their breathing like a normal newborn baby breathes, but they do have breathing movements, okay? And yes, when they breathe, they do inhale amniotic fluid, okay? But that's okay. They're used to that. They're not getting oxygen from their lungs, so it doesn't matter. They're getting oxygen from the placenta. So they're looking for fetal breathing movements. They want to see at least one, okay? And then they get 2 points for that. Then they're looking for fetal movement. So they're looking for a kick, an arm wave, something like that. They want to see 3 of those. And if they do, and I'm sorry, this isn't a 20 or 30 minutes. So in 20 or 30 minutes, babies have to do this. If they do that movement, they get 2 points. Then they're looking at fetal tone, at least one episode of them extending their arm and flexing their arm, or extending their leg and flexing their leg, or opening their hand and closing their hand. Those are extension flexion movements. If they see one of those, they get 2 points. And then they look at the amniotic fluid volume, and they're looking for an amniotic fluid volume of a greater than a 5 centimeter index. Okay, so an index is, they look at 4 pockets of fluid. So they basically divide the woman's uterus into 4 quadrants. In each quadrant, they're looking for a pocket of fluid. They measure the fluid, each pocket of fluid, and then they add all 4 of those up, and those should be greater than a 5 centimeters. And so they're looking, and so if they have greater than 5 centimeters, then the baby gets 2 points. Now, when we did our NST, if baby has a reactive NST, they also get 2 points. So the total pointage of a biophysical profile is 10. All right. Oops. Sorry. Oh, there it is. So if a baby scores 8 to 10, so maybe baby didn't pass our NST. Maybe we had a non-reactive NST. So baby did not pass our NST, so they got 0 points. But on all other parameters of the biophysical profile, or at least of all the ultrasound parameters, baby did everything they expected. So that would give baby 8 points. So baby 8 to 10 is reassuring. We can say, you're fine, your baby's fine, you can go home, come back and see us next week. But if the baby scores a 6, we call that equivocal. Like, we don't know if baby's okay. We don't know if baby's not okay. So we might keep that woman and put her on continuous monitoring for a 24-hour period, and see if we, over that 24 hours, if we feel okay about the baby. If we don't feel okay about the baby, then we're not going to let her go home. We probably will end up inducing our baby. Because here's the thing. If you have a sick baby in utero, they don't get better in utero. They get worse in utero. So it's not like, well, we're going to keep you until baby feels better. Baby will not feel better. Baby will just continually get worse, okay? So if they have a 6, we've kept them for a little while, we've watched them on the monitor for a continuous period of time, and we've determined after that time, you know, I really don't feel comfortable with this baby. We won't let her go home. We may not necessarily deliver her right away. We might keep her on continuous monitoring until the point at which she's either term delivery, or until the point at which we say, you know what, baby can't take this anymore, we need to deliver, okay? Now, if she scores 0 to 4 on that biophysical profile, that is completely non-reassuring. Our baby is having a very much difficult time, and we do need to deliver this baby, okay? This is a score where we do need to deliver. Now, we may be able to do a vaginal delivery, but then we may not. How do we know if we can do a vaginal delivery? Well, we're going to do this contraction stress test, which I don't see very often anymore. Especially if you have a baby on a monitor and you're seeing decelerations, you're seeing minimal or absent variability, you're not seeing any accelerations, and this is without the stress of labor. Like, I don't feel like the baby can tolerate the stress of labor, so we should go to C-section. But some people will be like, the mom really doesn't want to go to C-section. She really wants to try for labor. So we will ask the baby, can you tolerate labor? And this is how we ask. It's called a contraction stress test. All right. And so what we will do is we will induce contractions. We just want to induce 3 contractions in 10 minutes, and then we want to stop the induction. Okay, we're not doing an induction of labor. We're just trying to start some contractions. We want to see how baby tolerates those contractions. So we want to try to get 3 contractions in 10 minutes, and we want each one of those contractions to be at least 40 seconds long. Now, if we don't see, if baby doesn't have any problems with those contractions, so we don't see any late decelerations and we don't see any variable decels with those contractions, we will say that it's a negative contraction stress test. Now, this is kind of the opposite of the non-stress test and how we term the results. Negative contraction stress test is a positive finding. It is great. It is what we want to see if we want a vaginal delivery. What that means is baby is negatively stressed during a contraction. In other words, baby is not stressed during a contraction. Okay? Now, if the baby does show late decelerations with 50% of the contractions, which is 2, okay? If you have 3 in 10 minutes, then that's a positive contraction stress test, meaning that baby is positively having stress during a contraction. That we will not let that patient labor, okay? Equivocal means that we have some lates, we have some variables, but they're intermittent, and they don't seem very bad, so we don't know if the baby will tolerate this labor, but I know they won't. If they're having this with 3 mild contractions, they're going to have it with 5 strong contractions. Okay, so I don't like it. I don't want it. Unsatisfactory is we can't get the contraction pattern to even determine if baby is able to tolerate the contractions, or we're not getting a good tracing. We can't see what baby's saying to us. All right. Now, there was something else I wanted to say. Oh, how do we get the contractions? Well, typically we will start an IV and we will start Pitocin, just like we do for an induction of labor. As soon as we get those 3, and we'll keep bumping it up, but I think we bump it up more frequently. I think we do it every 15 minutes, 2 milliunits every 15 minutes instead of every 30. And the reason why I'm unsure is because we rarely do these, and I forget now. But as soon as we get those 3 contractions in 10 minutes, we turn the Pitocin off, okay? And then if we get a negative contraction stress test, and we decide maybe we want to send her home, or we don't want to start labor yet, or I don't know what we would decide, but we would wait until the baby until the contractions recovered before we sent her home. But chances are we're not going to send her home. We're just going to start her induction. Now, the other way we can do a contraction stress test is do what we call a nipple stimulation test. So what we do is we have the woman rub her nipples between her fingers for a minute, stop for 2 minutes, rub them for a minute, stop for 2 minutes, rub them for a minute, stop for 2 minutes, rub them for a minute, stop for 2 minutes, until we get 3 contractions in 10 minutes. Why does stimulating a nipple cause contractions? You guys remember, right? It's because the body doesn't know that that's her fingers and not her baby, and so it will release oxytocin to let down milk, and it will cause contractions. Okay. We had a patient this week in clinicals. She had a preterm baby because she was seeing some milk. I think the story is she was seeing some milk leak out of her breast. So she thought, oh, wow, I'll start storing this. Well, she started pumping, and she ended up in preterm labor and had her baby. Anyways, okay. And then vibroacoustic stimulation. So we kind of do this sometimes. It's a little device that we put on mom's belly. We hit this little button, and it goes, it makes a sound, and it vibrates. And so what that does is stimulates the baby, which is a nice word for saying scares the baby, and the baby does, goes, well, you can't see what I'm doing. The baby jumps, reacts to that sudden sound and vibration, and that reaction causes an increase in heart rate. So we will see those heart rate accelerations, okay? So we put this device on mom's belly, we push the button for 1 to 2 seconds. We can repeat it 3 times within a 1 minute, 1 minute in between. And I'm actually going to tell you to strike that. We hold it on the belly for 1 minute, for 1 to 2 seconds, and then 5 minutes later, if we don't have acceleration, we can do it one more time, but then that's it, okay? Because if you scare that baby, but that baby is so sick they can't react, you're not going to get a heart rate acceleration. So the first time, maybe baby, I don't know, maybe their heart rate didn't go up. Maybe they didn't, I don't know. The second time, we'll try it one more time. And if we don't get an acceleration or a reaction from baby, then we stop, because if we have a stressed baby that's not reacting, I'm not going to stress it anymore, okay? So this may be repeat 3 times with 1 minute intervals. That may be what the textbook says. I do not have a question on my exam about vibroacoustic stimulation, okay? And I don't know what NCLEX says about this. So this is one of those things where you kind of got to remember 2 rules. So if NCLEX asks you this question and your only possible answer is repeat 3 times with 1 minute intervals, then that's the correct answer. But if it says, you're going to hate me. If it says repeat 1 time in 5 minutes, then that's the correct answer. But they're not going to have a vibroacoustic stim question on there. Okay? Just trust me. Oh, that's the end. All right, so let's see how long that was. I have no idea. Oh. Okay. That was 1 hour and 20 minutes. Okay. I am going to close this, and I am going to go take a break. My animals are running crazy in my house. And then I'm going to record less than a 30-minute lecture on pain, okay? And you probably already know that because you see the link to that. So good luck on your test. Focus on nursing interventions, fetal heart rates, anyways, I can't remember. So study everything. Huh? Okay.